Well, hi, everybody. Thanks so much for joining. I hope everybody's safe and staying cool and dry if it's been raining or getting rain if it's been dry. And we're going to get started here. This is Carol from the Society of Thoracic Surgeons, the Adult Cardiac Surgery Database webinar, monthly webinar for June 7th, 2023. On the line with me from STS, we have Leanne Jones, Emily Conrad, and Sydney Clinton, and Andy Dolan, Melinda Offer, and Nancy Honeycutt. So thanks all for joining. We're going to go ahead and give some STS updates, and then Melinda has education for us today on chronic lung disease. Oh, Giselle, I see your hand is up. I'm not sure if you had something to talk about, but I'm going to go ahead and we'll get to you in just 1 second. If you're having any problems, please put it into the Q&A box. Thank you. Okay, 1 second, everybody. Sorry about that. Okay. STS updates, the webinar posting. So we underwent, as probably most of you already have figured out, we underwent a major website redesign for the sts.org. And with that web design, things look a little bit different, but everything is still here. The one thing I wanted to talk about, one thing I want to talk about is the recordings for the webinars. I know a lot of folks like to pull those up afterwards and re-listen to them, or if you're not able to join on to the live webinar, you listen to them afterwards. And they will still be posted. We're just going to have to save them in a different spot, which shouldn't impact you all that much. But here is the tab. So I'm at the sts.org, and then I went to registries, data, the data manager resources, and I just scrolled down a little bit to the adult cardiac webinars. This is webinar recording for the most recent one, and then the slides are posted here. The webinar recording, even though the most recent one is here, this will take you to the YouTube channel where all of them are posted. All of the adult cardiac webinars are posted. If you participate in other databases, you can easily get back to the library for congenital and general thoracic by clicking the STS National Database link. And you could see here is the playlist. So Intermax, general thoracic, adult, and congenital. So that's one thing I wanted to show you, just because it says webinar recording. This will take you to the last recording, but from that page, you could also get to the previous recordings. And then the monthly webinar slides, we have size limitations, storage limitation for the new website. So we'll be storing these kind of offsite, but we'll link to the offsite location here. So you could still access all of the webinar slides, because I know folks like to print those out. That was all I had for that. And then the training manual, Melinda made an update to the June training manual, and that was reposted today. So if you've downloaded the June training manual for any reason, or you're linking, you were downloaded it onto your desktop, please make sure you re-download the updated June training manual. Hopefully you're not downloading them and you're just using the link so you get the most recent one. But if for some reason you did download it, make sure you revisit that page to get the updated June training manual. Harvest 2 data is currently in analysis in the STS Analytic Center. We're working on that, and AQO registration opened earlier this week. All right, and then here's our timeline. Today's June 7th is the monthly webinar. June 8th, which is tomorrow, we have our new data manager webinar. Melinda will lead that. That's at 2 p.m. Central Time. It too will be recorded. June 21st, we have our Quality Improvement Series webinar. Nancy Honeycutt will be presenting on her institution maintaining early extubation rates of 88% for over 3 years. Canceled webinars for June 29th and July 5th. I canceled webinars for June 29th and July 5th. I'll be out of the office, and I assume a lot of other folks will be too, and just getting back on July 5th, so playing catch up. So I didn't want to burden us with the webinar when we come back. So our next one after June 21st will be July 19th, and that will be Diana Alejo presenting from John Hopkins on their dashboards that they use for reporting and quality improvement. August 2nd is the monthly webinar at 2 p.m. Central. August 16th, if anybody has a quality improvement for a prolonged event or for increasing early extubation, if anybody has done a protocol or updated any of their processes, please reach out to me and I'd love for you to present that for everybody on August 16th. Otherwise, we'll just be going over the database longitudinal reports and the outcomes. August 18th, Harvest 3 closes. That contains OR dates through June 30th, 2023. It is the star rating period. And August 22nd is the opt-out for Harvest 3. So that gets us through the next couple months. Harvest 2, this is just another snapshot. Harvest 2, it's currently in analysis. Harvest 3, that is a star rating. It closes on August 18th. Opt-out is August 22nd. Make sure your data is in and cleaned up as quickly as possible. And, oh, I wanted to talk to you all. I don't know if I can do a quick poll. Hold on one second. I just want to ask a quick question. I'll launch it. It's a polling. I know it says risk A and B, but we'll just pretend that it says yes or no. Option A is yes. Option B is no. How many of you currently participate in the general thoracic database? So option A is yes. Option B is no. Okay. So it looks like it's 65, 35, right around there. Thanks everybody for responding. I'm just going to end it and I'll share the results. So recently the STS General Thoracic Database was offered by US News and World Report to receive 3% transparency credit for public reporting of the lobectomy. This is a big draw to sites who are interested in getting those transparency credits with US News and World Report. So I wanted to bring this to you all today to pass it on. If you're not already participating in general thoracic, if you are, that's great news. And I'm sure you're already aware of these transparency credits. In addition to participating in general thoracic and receiving the transparency credits, sites participating also receive biannual benchmarked outcomes. So the data is harvested twice a year for general thoracic, where adult cardiac is 4 times a year. And you receive regional and national averages to use for quality improvement. To participate in general thoracic, it's a very low fee. So we're looking at a per surgeon fee, so $550 per surgeon member if the surgeon is a member of the STS, or $950 for non-members per year. There's a $3,000 one-time onboarding fee for Canadian and international sites. So it's actually very inexpensive when you think of the 3% transparency credit that you get, and then the outcomes, the regional and national benchmarked outcomes. The other thing to consider that hopefully you see the bargain in is that it's free to submit this data with direct data entry. So if you participated, you're performing very few thoracic or esophageal cases. You could actually, you have a couple surgeons at your facility performing these cases. The fee is very low per year per surgeon fee. And then you enter the data for free into direct data entry and get those reports back. And we collect primary lung and primary esophageal cancer cases. So if it's primary lung, not METs to the lung, but primary lung cancer or primary esophageal cancer, those cases are required. Some sites submit other thoracic cases, but it's not required to participate in the database. So it's very focused on primary lung, primary esophageal cancer, low member fee, and free direct data entry. to get the 3% credit back with US News and World Report. So I just wanted to bring this to your attention. If you're interested in getting more information, you could always reach out to me at ccrone@sts.org. I'm happy to pass you along to my team members. And then also, if you have any questions about data abstraction or how the database works, Leanne Jones is the STS staff member, National Database Manager for General Thoracic, and her and our clinical consultants can help with those questions. But I'd really like to draw your attention to this. If you are interested in earning that additional credit with US News and World Report, this is a great way to do it for a low fee and also get your regional and national benchmarked outcomes back. Okay. Speaking of public reporting, I just wanted to point out a couple deadlines here. We have the adult cardiac surgery database public reporting deadline. If you have not yet consented and you need to consent for public reporting, you do not need to reconsent if you've consented in the past, as long as you haven't rescinded. But if you are new to public reporting, that deadline is September 4th. For congenital, that deadline has already passed, and for general thoracic, that deadline is July 10th of 2023. I know you can't click on the links here, but this is a QR code. If you wanted to scan that with your phone or take a picture and open it later, you certainly can. So those are the deadlines for public reporting. If you're new to public reporting for adult cardiac, make sure you get that consent in on time. Otherwise, you'll be pushed to the next round of consenting. And then AQO is 2023 will be virtual, 2024 will be in person. For 2023, we're looking at the dates of September 26th through the 29th. And adult cardiac will be on Thursday, September 28th. It'll be the day designated to adult cardiac. We're looking to hold the Hot Topics webinar, similar to what we did last year. We're looking to hold that the first week in December, just to give us a couple weeks to get the information back from AQO and to prepare presentations. So we're looking to do that in early December, before the end of the year. Registration is open. There is, these are the prices. Member is if you are a member of the STS as an associate member. If you're a physician, you're a physician member of the STS. If you are not, you would be a non-member price. One-day member is $200, non-member is $250. Multi-day member, which includes all 4 tracks, adult cardiac, general thoracic, congenital, and intermax PDmax, that would be a $300 price, and multi-day non-member is $400. Vendors and industries $500 for the multi-day pass. Abstract submission is open, so if you're interested in submitting an abstract on any quality improvement project using the STS database, those deadlines, deadline is July 5th. Please get your abstract in so we can hopefully review it and get you some recognition, well-deserved recognition at AQO for wonderful projects. And that's it. I'm going to take this one question. It says, are audits ongoing? So the audit process, Emily, are you on? I don't think we've sent out letters yet, right? They're coming soon.
Correct. Yeah. The STS Research Center is in the process of getting the data ready, and then we'll be sending it off to our audit company so that we can send out notifications and instructions. More to come soon.
Great. Thanks, Emily. And then when will public reporting be updated? That'll be updated late fall. Or I'm sorry, late summer, early fall. And all right, Melinda, it's all you.
All right, great. The only other thing I wanted to mention before I get started here is that on the new data manager workshop tomorrow, I had to redo all my slides. So it's kind of a good review of the new website, just FYI, if anybody needs that. So, because I'm going to go through and tell you where to find everything. So, all right, so we're going to talk about chronic lung disease. We haven't talked about this in a while, and we're continuing to go through risk factors. So, of course, chronic lung disease is in the risk model, and in 2022, it was an audit field. And as you know, most audit fields are risk model fields. So when we look at this definition, indicate whether the patient has chronic lung disease and the severity level according to the following classification. And we have this pretty extensive classification in the training manual. And it's based on pretty much objective data, whether it be your FEV1, or are you on a chronic inhaler, or are you taking systemic steroids, or do you have a room air ABG? So, and then we even go further into the next slide talking about the DLCO and values for that and how that all plays into chronic lung disease. So the one point I want to make here is when we are determining the severity of the chronic lung disease, it's determined by these objective factors. It's not determined by physician interpretation, like he says it's severe. Okay, so you have a documentation, the doctor says this patient has severe COPD. There has to be proof, the subjective proof, whether it be your DLCO, your FEV1, your ABG. You have to, the severity has to be determined by that criteria, not necessarily just physician documentation. So I kind of wanted to get that out in the open first, because I get a lot of questions about that. The physician documents this, but the FEV1 is this. You know, which one do I go by? Okay, so you go by the objective data. All right. Okay, I think we can go on. I'm not going to go over the whole definition. The other thing I do want to point out is that when you're looking at your objective data, you want to code the most severe category if there's a difference. You know, for example, if your FEV1 is 60, your DLCO is 45, and your ABG-PO2 is 50, you look at all of those factors and then code the most severe category. So in this case, it would be severe. So it's not, you're not just looking at one of those criteria, look at all of them and then code the most severe level of chronic lung disease based on that particular, based on the criteria that you have available. All right, next. Okay, so we're going to do some questions, and I think that hopefully this will help you guys understand it a little bit better. Okay, so question number one. I have a patient that states they have a history of COPD. The FEV1 is 82. No DLCO was done. The patient is on an albuterol inhaler. So how do you code for chronic lung disease? Is it no, mild, chronic lung disease, documented, severity unknown?
I was just talking to myself. I was double muted. I could give folks a few minutes or a few seconds extra to open up their training manuals if they need it. You tell me when you want me to end it. Okay, Melinda?
I can't even see the poll running, so I don't.
Oh, Lord, I did it again. Hold on.
Yeah, so
Let me
I don't
fix
know
it.
if it's, I don't know if they're answering questions or not.
There you go.
Okay, I think that's pretty good.
Okay. All right, I'll end it.
All right, okay, so next slide. And the answer is mild. Okay, so what do we have here? So we have an FEV1 of 82. Okay, so that's normal, right? You didn't have a DCL done, so you can't use that. This wasn't done. It is, the patient is on an albuterol inhaler, so that falls into the mild lung disease category. So this would be mild chronic lung disease. Question number two, patient has asthma. The FEV1 is 77%. Hold on, I can't read the rest of the question. Patient is
I
on a
didn't mean to, I didn't know it was
That's
gonna do
all
that.
right.
Sorry.
Patient is on a ventral inhaler at home. How do I code chronic lung disease? So you have an FEV1, 77. They got an inhaler at home. Is this no chronic lung disease? Is this mild, or is this moderate chronic lung disease? Oh, everybody's doing good. Doing good. Okay, that's probably enough time.
Because you taught them so well, Melinda. I think that's why.
I think we can end it. 82% of the respondents say mild, and that is the correct answer because the patient is on the inhaler at home. And again, asthma, in the old days, we didn't really consider asthma, but we do consider asthma starting in 2.9. We consider asthma if the patient meets the criteria, which in this case they did. Okay, question number 3. Okay, for a current smoker, how do you code chronic lung disease? No inhaler, no ABG, no PFT performed, no documentation of lung disease. So is this no chronic lung disease, mild, moderate, or chronic lung disease severity unknown?
Hmm.
Well, their fingers are fast.
Yeah, they are. We're gonna shut down Zoom because their fingers are so fast. It's going to be overloaded.
I think we can stop. We got 90% of the people saying the answer is no chronic lung disease. And the answer to this question is no chronic lung disease. So again, and I think this is an important point, not all smokers have chronic lung disease, okay? So just because they smoke does not mean that they have chronic lung disease. You've got to have criteria to code the severity of chronic lung disease. And in this case, there's no criteria at all to even say that this patient has chronic lung disease. All right. Okay. Question number 4. Patient is on a Symbicort steroid inhaler at home for his COPD. No PFT, no ABG. How do you code for chronic lung disease? Is this mild, moderate, or chronic lung disease documented severity unknown? Symbicort steroid inhaler. No PFT, no ABG.
Oh boy.
Yeah, I knew this one might cause a little,
Mm-hmm.
but not, I think it's the split's not as wide as I thought it would be. So I'm happy to see that the majority of the people are answering this as mild.
You
We
gave
got,
away the answer, Melinda. But
I
have
know.
to All right, here we
So we're
go.
going to end it. And the answer is mild. Okay, so why is the answer mild? Let's talk about why it's mild. So first of all, this is a steroid inhaler, okay? But that qualifies as inhaler. It does not qualify as a systemic oral steroid therapy aimed at lung disease. So inhalers are non-systemic delivery modes. So if the patient had been on oral steroid, this would have been moderate chronic lung disease. But since they were on a steroid inhaler, this is only mild chronic lung disease. All right.
Thank you.
Next question. Question number 5. Patient has a history of COPD on daily bronchodilators. The FEV1 is 87. The room air ABGPO2 is 65. So we have no chronic lung disease, mild chronic lung disease, or moderate chronic lung disease. Okay, you got inhalers. Your FEV1 is 87. Your room air PO2 is 65. Okay.
Their fingers aren't as fast on this one.
Yeah. I think we can end it because I don't know how many questions I have. I kind of want to get through them. All right. So 62% of the people said this was mild, and it is mild. And when breaking it down, you've got a normal FEV1, but in your ABG, the PO2 is above 60. So that's doesn't play into the criteria at all. But this patient's on an inhaler. So that plays into the criteria. So remember, if you have multiple criteria, take the most severe coding based on the criteria that you have. So in this case, we would code mild because the patient's on the inhaler. All right. Number 6, patient has COPD in his own home oxygen and uses an inhaler. No PFT or ABG done. How do you code chronic lung disease? Is this no lung disease, mild lung disease, moderate lung disease, or severe lung disease? Well, we've established the fact that it is lung disease. That's good.
Yep, very good.
But what kind is it?
And somebody was asking where the training manual is located. I don't know if Emily, you're able to send the link where they need to log in. It's the most updated training manual is posted on the STS website under the ACSD resources.
I'll send it.
Okay, thank you.
I think we can close now. 64% of the people answered this as mild chronic lung disease, and it is mild. So why is it mild? The patient's on an inhaler. Home oxygen is not in the criteria, so it does not play into severity at all. So keep that in mind. This patient was on an inhaler, had no PFT, had no ABG. So the only criteria you have to use in this situation is the inhaler. And that causes mild chronic lung disease. All right, next question. Patient is on a home inhaler. No PFT or ABG done. Pre-op CT and radiologist documents severe emphysema. How do I code chronic lung disease? Mild, severe, chronic lung disease, severity unknown.
Tricky, Melinda.
All right. So we're like about 80% of the people are going for mild. So the answer is mild. Okay, again, we have to use the criteria. We can't use the documentation by the radiologist because in the definition, chronic lung disease is determined by the criteria. So the only criteria that we have here is a home inhaler, and that only qualifies for mild. So that's all we can give this patient. You know, if this patient had had a PFT or an ABG done, probably would have had more severe lung disease, but they weren't done. So the only criteria you have is mild, inhaler, which is mild. Somebody's got their hand raised.
Yeah, I think it's been raised. Let's see. Teresa.
No, somebody named Giselle, I see, has a raised hand.
Okay. Are you there, Giselle? I see Teresa's hand raised too. All right. Oh, stop it, Kelly Moore. Quit faking me out. Okay, I'm gonna lower your hands.
Okay. All right.
Okay.
I'm going to number 8. Okay. PFT was done 1.5 years ago, which shows severe COPD. Patient is on an inhaler and oral steroids at home to control chronic lung disease. How do you code chronic lung disease? Mild, moderate, or severe? So your PFT was done a year and a half ago. Patients on an inhaler and oral steroids at home. All right, well,
All right.
65% of the respondents answered this as moderate chronic lung disease, and it is moderate. So why is it moderate? Well, first of all, the key here is the PFT time frame. It's 12 months prior to surgery, okay? So we can't use that PFT that was done a year and a half ago. And then when we look at the other two criteria that we have an inhaler, but we also have oral steroids. So oral steroids elevates you up to the moderate category. And these steroids were specifically used to control the patient's lung disease. So we can code this patient as moderate lung disease based on the use of the oral steroids to treat his or her disease.
Thank you.
All right. Question number 9. Patient has COPD, no inhaler at home. Pre-op FEV is 94. Room air ABG has a CO2 of 33 and a PO2 of 90. How do you code chronic lung disease? I only got 2 answers here. No chronic lung disease or chronic lung disease severity unknown. Because if you look at that FEV, that's normal. ABG is normal. There's no inhalers. I knew this would cause a split. I knew it would. The key is chronic lung disease severity unknown. I mean, when you look at this, looks to me like you know what the severity is. You got an FEV1, you got an ABG, you got no inhaler. We're going to end the poll now. So no, this is no chronic lung disease. I mean, you've got pretty much all the severity, everything that's pretty much in the criteria you have available for you. And the severity shows that per the criteria that this patient does not have chronic lung disease, despite the patient saying he has it.
So what would you do with this? Say that in the physician notes, you see that, you know, in the consult that they put patient has COPD, and then they list all of this and all of it's normal. How would you, and we're coding off the criteria, but how would you work, or what's your suggestion for working with the surgeon or whoever documented COPD on this case?
Well, you see this all the time. I mean, it's hard to, I mean, you can work with your surgeons to say, hey, you know, you documented this, but per this criteria, it doesn't meet the definition of lung disease. I'm not sure that's going to stop the surgeon from writing lung disease, but I mean, the important thing here is the definition in the training manual says that we have to use criteria. If we have all this criteria available at our fingertips, then we know what the severity of this patient's lung disease is. And so it's not unknown because we have an FEV1, we've got a normal ABG, and the patient's not on an inhaler.
Okay.
So we need to go by the definition, basically, is what I'm getting at.
Yeah, that makes sense. I could see though why 40% of the people coded CLD, chronic lung disease severity unknown, because you're seeing this written somewhere, but
right, you are seeing that written somewhere. But again, when you look at the definition's clear that it has to be determined by the criteria, not documentation. So, and I see this all the time. Doctors do this all the time.
I'm sure they do, because I mean, and it's clear, we have a 60-40 split, so it's clear that it's being coded. COPD is being coded as when it's written like this, that it's being coded even if the criteria is not met to code CLD. So it's good that you went over this. I'm sure it's very tricky though when you see that you're so anxious to want to code chronic lung disease, but patient doesn't fit the criteria.
And the other thing to say is when this harvest out anyway, I mean, no and severity unknown is basically only going to be grouped probably together as a no. So it's just it's kind of, in my mind, sometimes it's a moot point, but especially if it harvests out the same way. Do you know what I mean, Carol?
Yeah, absolutely. Yeah. The risk is the same for CLD severity unknown versus no CLD. I don't know if that's true or not, but my guess is it is.
Yeah, I think it is. So that's why, but I get these questions all the time. So just to bring it up.
Yeah. All right,
Okay,
thanks for entertaining my question.
I think it's Laura has her hand raised, it looks like.
Okay, here we go, Laura. Let's see what happens. Oh. Okay, try it again. Go ahead, Laura. I don't think we can hear you. All right, you might want to put it in the Q&A because we can't hear you. Let's go to the next question, Melinda.
Okay, question number 10. Patient has COPD, no inhaler or ABG. The FEV1 is 68. The DLCO is 59. How do I code chronic lung disease? So we've got some criteria here. So we'd want to specifically look at the criteria and determine what this is. Is this mild, moderate, or severe based on the criteria that we have? Yeah, I have to look in my training manual too, because I don't always memorize all these numbers.
Uh-huh.
That's what I'm always like, oh, what is that? What is the cutoff, kind of thing, looking at it.
Okay.
And then most of the people said it was moderate. We have 70% of the respondents saying that this is moderate chronic lung disease. And the answer is moderate. So why is it moderate? Well, when you look at the DLCO, 40 to 60% of predicted falls into the moderate category. So even though the FEV1 falls into mild, the DLCO falls into moderate. So we would take the more severe of the criteria and code this as moderate.
Thank you.
All right.
Oh, that's it. Time for
That's it.
questions.
Good. Well, good, because we have lots of questions, it looks like. So
Yeah, looking good. Okay, let's start back at the beginning here. And I'll just put this up there. Okay. Are bedside PFTs acceptable for FEV1s?
yes.
Number 2, if pulmonary function test was greater than 12 months, can we just use physician's documentation?
You can't use physician documentation at all, basically. I mean, unless he says the patient's on an inhaler. I mean, that's a home medication. You can use that. But as far as the severity goes, it really has to do with the criteria. So if the physician documents the patient has a room air PO2 of da-da-da for an ABG, that's different because you've got criteria. But if the physician's documenting the patient has severe emphysema, that's a whole different ballgame than documenting the criteria that are involved in determining the severity.
Okay, thank you. So what if the patient has severe COPD in the history and with treatments, the COPD is better? How do you code this question mark by the most recent PFT question mark?
Right. You want to code by the most recent criteria that you have. So if severe was, 2 years ago, you can't use that if that's a PFT from 2 years ago. You can't use it if it's a PFT from greater than 12 months. So you'd want to use the closest criteria to the patient's operative procedure to determine what the severity is.
Thank you. In terms of coding severity, if the FEV1 is normal, but the patient is on chronic oral or systemic steroid therapy, would you code it as moderate then?
Yeah.
Okay.
If the systemic oral therapy is aimed at lung disease, if it's not for something, I mean, it has to be targeted to treat their lung disease, Erica. Okay. So, because some people are on chronic steroids for other things. So it has to be targeted to treat that lung disease.
Thank you. What if they're on inhaler PRN, which is as needed only?
It counts because what's PRN to one person, might be every 2 hours. It might be every 4 hours. Who knows when they use it. So it's acceptable. It's a chronic inhaler that they use when they need to for their lung condition.
How far back are PFDs good to use?
12 months.
And this is just for clarification, can you code lung disease without diagnosis if criteria is present?
Yes.
Why doesn't home O2 count?
It's just not in the criteria. It's not in the definition. We have a separate field for Homo 2 where
And it's a
that
separate
captures,
risk. It's a separate risk factor too. Yeah.
that's what I was going to say. It captures its own risk in a different field.
If CLD coded severity is coded as unknown, how is it counted in the risk model?
As no, I believe.
Yeah, it's either no or mild. It's either it either
think
defaults to mild or it counts as no. I would have to double check on that.
I think it's no, Carol.
Okay. I know we had a lot of conversations and you know that. Okay. When would we select severity unknown?
Well, okay, severity unknown would be in a case like, let's say you have documentation from your provider that says the patient has COPD, but you got no inhaler, you got no FEV1, you got no ABG, you got no criteria at all to determine that severity. So then you can use severity unknown. Yep, I see it, it's documented there, but I have no idea what the severity is of this patient.
Thank you. Okay. That was the next 3 questions. Patient has a FEV1 of less than 50%, but has recent active pneumonia or CHF exacerbation. Do we still capture severe chronic lung disease?
Yeah, per the training manual, you do, because that patient's probably going to probably be going into surgery with that risk level, is what I'm thinking.
Yeah. If not stated that patient has lung disease, but testing shows positive for it based on the criteria, how is it coded? You code it off of the criteria.
Correct.
So if patient had PFT 1.5 years ago and is on home O2 chronically, that is all you have.
That's all you have. Well, if that's all you have, then you probably could say, if you could probably say the lung disease unknown, the severity, if that's all you have, because the patient's got lung disease, they're on O2 at home for some, lung issue, but you've got no criteria. So I would just say severity unknown.
Right. So when we're talking about coding based off of criteria, we're talking about coding the severity based off of criteria, right?
Right. The severity.
No CLD or CLD severity unknown, both would be no, right?
I think they both harvest out basically as no, like in the risk and all.
During my audit, because physicians had charted lung disease, but I didn't have criteria, I missed that point because I put no for CLD. And that's where I think what we're talking about, what we were just talking about is this isn't for coding chronic lung disease, but it's for coding for the severity of lung disease. Right, Melinda?
Well, no, it's that our field
405
is chronic lung disease, and it's coded based on the criteria. So Stephanie, if I don't know who audited you or when you were audited, but maybe you could send that information in, because that might be something that we have to work with the auditors on. Right, Carol?
Said my audit physicians had charted lung disease, but I didn't have criteria. I missed that point because I put no for CLD. But didn't we just say we would code that as severity unknown?
Yeah, we would. So that's why I say I don't
Yeah.
know exactly what she means, what the audit said. I don't know.
Yeah.
Do you know what I mean? The exact details of
You
why.
would code lung disease documented severity unknown for that case. But yeah, send it in, Stephanie, so we can review it.
Just to make sure that Yeah.
Okay, when determining type of CLD, so we're talking about type. If the pulmonologist says, oh, your question is talking about severity. So when determining severity of chronic lung disease, if the pulmonologist says mild or moderate or severe diffusion effect, what type of CLD is this?
I don't know. I'd probably need more information, Marina. Can you send that in to the FAQ mailbox?
Suzanne's question on question number 9. If you don't have all the criteria listed, well, let's go back here. If you don't have all the criteria listed, we may have in parentheses, we may have a PFT but no ABG. Would we still code as no COPD? I almost never have a PFT or ABG.
I think as long as you have criteria available to determine severity, which is most often the FEV1, hardly anybody has an ABG. Then you know what the severity is. The FEV1 is pretty much gold standard for the severity.
Okay. And what if the MD documents COPD, but there is no criteria to use? And can we use lung disease, no severity
Right.
documented? Yep.
We can, because you got no criteria. You don't know if they have it or not.
Marina has a sticky note with the criteria on her computer. Good idea. That's what I was going to say. I would have printed it out and taped it onto my computer. What do you code if the patient had an albuterol inhaler in the past, but not on recent admission? Also on singular, no mention of asthma or PFTs.
So they're not on an inhaler because it has to be like on an inhaler. So if they're coming in and they're not on an inhaler, then they're not on an inhaler. Because I don't know how long they've been off the inhaler or anything like that. So I would just
And
say
when
no.
we're saying the patient's not on it, we're saying that it's not prescribed for the patient anymore, right?
Yeah, that's what I'm. Yeah, I
Okay.
mean the patient has to be on a chronic inhaler. So if they're not, they don't have
Okay.
it prescribed anymore, then I would say no. And as far as the singulaire goes, if I'm not mistaken, that's a pill, I think. So that doesn't really factor into the criteria at all.
Okay. If there's no PFTs or ABGs and no inhaler, all right. Can you use? No, you
No,
cannot use the physician documentation of mild COPD. You could say that the patient, you have to code the severity based off of the criteria provided in the training manual. For this
right.
patient, Melinda, even though the physician documents mild COPD, would you document that as chronic lung disease severity unknown or not
I
documented?
I
Yeah.
would because you don't have any criteria to determine if it's mild or not.
If emergent case and no pre-op labs or tests are available in the physician note COPD, how would you code that?
Chronic lung disease severity unknown.
Is ABG result in the CLD definition? Is ABG in risk calculation? So no, the ABG is not used in risk calculation,
Mhm.
but it is used in the CLD definition.
It is.
What if what if the physician documents restrictive
In
in
the
the
H,
H&P?
I don't know. I'm assuming that's restricted lung disease. I don't know, Jennifer, what you're asking exactly. Again, if we're talking about severity, you still have to be able to determine the severity of that restrictive. What's the next question? If a provider documents CLD or COPD, but none of the criteria is documented, no steroid, no inhaler, no FG, can you document chronic lung disease severity unknown? Yes, you can, because you've got some documentation that they have lung disease, but you do not have any criteria to determine the severity.
Same idea, but all you have on that patient is an FEV1 that's normal. What would you code for that severity?
I'd code based on the FEV1 because you have a criteria. You don't have, the definition does not say that you have to have all the criteria. The definition says it's based on the below criteria. So most people only have one of the criteria, FEV1 or one, or they might just be on an inhaler. So when you're looking at the criteria, you don't have to have all the criteria, but you have to have criteria to determine. So you've got to have at least one of those criteria to determine your severity.
Next question. I'm going to pull up the training manual because I think this is, oh, God, no. It says patient has no diagnosis of COPD, no inhaler, bedside pre-op spirometry of FEV1 is 58%, which is moderate severity, and type is not documented. Is that correct?
Sounds correct. You got an FEV1. It would be 58. That's moderate, but the type would not be documented. What if they are prescribed an inhaler, but the chart clearly states they are not using them? That would be something we'd have to look on an individual basis. How long have they not used them, and did they just stop because they don't have lung disease? I mean, that's kind of a, you just got to kind of look at that.
Yeah. GTSD accepts this for DLCO. Would this be accepted for the ACSD DLCO adjusted CO diffusion capacity percent predicted? I realize this has adjusted.
I don't know what that means. We'd have to talk to Ruth about that. Send that in, Mary.
Yeah, I think she's
I don't know
well,
what.
let's talk about that one offline because I talked to Ruth about this. I have to see what the difference is
Yeah,
in our training manual. Patient has COPD, but CT shows by CT, but no other testing. Would you code COPD severity unknown?
correct.
I've been trying to get normal reference levels for DLCO from our respiratory department, but I'm being told normal is different for each patient. Is that correct?
Not that I'm aware of, Doc. I think that you should work with your RT department. Most of the examples that I've seen sent in, there are some normal levels, reference levels for that.
But if there's a diagnosis of asthma and the patient's on albuterol PRN only, no other criteria documented. In anesthesia record, it is marked as last used over 1 month ago or infrequently used. Is this considered to be chronic inhaled therapy?
I think that if the patient has a prescribed inhaler to use when they need it for their lung disease, that you can code that as mild.
Thank you. You might have said this if the patient has completed PFT within 1 year, but has a bedside spirometry closer to surgery. Do you use the bedside spirometry or do you use the PFT that would be more accurate?
I think it's the one closest to surgery.
If there is no PFTs or inhalers and the room area EBG results are within normal limits, but the surgeon documents mild COPD, can we code mild?
No.
I don't understand. We cannot code off a surgeon. We can't
Doc-
code the severity off of surgeon documentation. There
You
has
can't.
to be criteria in order to code severity. So even though the surgeon says mild COPD, you still have to look at the criteria in order to code the severity. If you don't have criteria that meet that if you don't have results that meet the criteria listed, or the testing was not performed, you would code it as COPD severity unknown or not documented. Related to harvesting an IQVIA report, seems the reports are not loading as fast. Was told by help desk that it can take 10 to 15 minutes to load. Is this the new norm? Report criteria was only 1 month, totaling 27 patients. Gail, can you send this into the STS database help desk at this email, stsdb_helpdesk@sts.org. We're probably gonna need more information as to what you were loading and things like that to look into it with IQVIA. No, it should not take 10 to 15 minutes to load. What if the patient has asthma on inhaler, but no PFT ABGs? How do we code type of lung disease?
I think that's clearly defined in the training manual, but let me see if I can pull it up. Because I have to
I
read
think
it
I got it
myself.
here, right here, right,
Yeah.
Melinda?
I have to read it. Asthma is an obstructive disease. Asthma, as noted in the prior section, creates reversible obstruction. Because we don't, yeah, I believe that's where it falls into now after we updated all the training stuff. It's more of an obstructive disorder.
Yeah. Okay. Can you discuss utilizing FEV1's pre-bronchodilator versus post-bronchodilator?
Yeah. Okay, now I don't like to misspeak myself. So if you were sending me this question, I'd look at my training manual. So Carol, we need to go to the FEV1 section because it clearly talks about that in there. And I can't remember that sequence number. It's like 4 or something. 420. So let's look at
Oopsie,
420.
hold on. I'm getting there. 1 second.
It's under sequence. Okay. 420 talks about using the highest. Okay. Choose the highest value reported with or without a bronchodilator. So, Erica, you would use the highest percent reported, whether it's with the bronchodilator or not, per the training manual.
I think what we're looking for here is the patient, by doing that and by coding the highest value is we're looking at the patient's best FEV1 pre or post bronchodilator, whatever the best FEV1 is, which is indicated by the highest FEV1. That's what we're looking for. Okay. I'm trying to find my results.
Okay, that's all right, Stephanie. Just whenever you find it.
Can you discuss the DLCO for mild?
Right. So when we updated the training manual in November of 2020, if you slide down, Carol, just a little bit further to all the DLCO information. Dr. DiAgostino worked extensively with some pulmonologists to try to get the DLCO added into the criteria because we kept getting so many questions about why can't we use this to determine criteria. So when we look at mild, it's the DLCO or the DLCO VA greater than 60%. So first of all, it's got to be greater than 60% and lower than your normal for your lower limit. So just like Jock was a few minutes ago was that saying his RT department said there's no normal for that. So there should be a lower limit normal. You know, for example, most sites is somewhere the normal values somewhere around 80 to 120. So meaning if you were less than 80, that's below your normal limit. So if you have a DLCO, which is greater than 60, but less than 80, which is your lower limit at your site, then that would be mild, considered mild disease. Does that make sense?
Yes. Okay, I think we're at time and thanks, Mary. I think we're at time and I have to hop off on another call. I don't know if you want to stay on, Melinda, and answer these.
I can try. It looks like some of this is
Let me
2000.
text Leanne,
Yeah.
real fast
Yeah,
and see if
that's
she
fine.
needs
I
me.
can think, how many more do we have here?
20.
A lot more. Ah,
Yeah.
okay, I'll try to do as many as I can. I can
Let
do
me
as
see if
many.
she needs me. Hold on. Let me see 1 second.
Jackie, how does Trilogy factor in? I don't even know what that is. Is that a new drug,
Okay.
Jackie? I don't
Trilogy.
know. I have no
Let's
idea. I don't know
let's
what that
Google
is.
it. Okay. I just told her to text me if she needs me.
Is it an inhaler?
Yeah, it's an inhaler.
All right, so it's inhaler. So it would fall into inhaler, I guess.
Yeah.
New drug. All right. It doesn't matter if it's a steroid inhaler. It's still an inhaler. So that
Okay.
goes into mild.
Okay. As long as that's the only criteria that's met. Last time I was audited, I got dinged for saying yes to lung disease based on the criteria. They said I needed to have MD documented. I couldn't use just the criteria. Yeah, that was a long time ago.
That was a long time ago. We've had a lot of
But
changes
she
since
thinks
then.
about it every night before she goes to bed.
Oh my
So,
God, have mercy.
I'm
Please,
sorry,
Donna, don't.
Donna. Yeah, let it go, Donna. Let it go.
We've lots of things have changed since 2017. A lot more
Yeah.
clarification in the training manual.
But I understand that's frustrating. Singular would fit here. Mild FEV 160 to 75, or of predicted or on chronic inhaled or oral bronchodilator therapy, since it's an
Oh,
oral bronchodilator.
thank you, Amy. Thank you. Great.
Thank you, Amy. So the big question is if severity is unknown, does this default to mild or no for the risk model? Sounds like it defaults to no.
I'm about 100% sure it defaults to no.
Yeah, I'll double check with analytics, but I think Melinda's correct, but I'll just double check with them since they're the boss on that. If document COPD and PFTs give diagnosis of restriction, how is it coded?
I don't know what PFT gives diagnosis of restriction. I guess you're talking about type of lung disease. Oh, I see. Because COPD is usually obstructive. I think I would have to clarify because you can only pick one, and it might be mixed. You might have both, so I would clarify. Or multiple is the word. Might be multiple, or it could,
Yeah.
or
Okay. Singular X is bronchodilator and is used for asthma.
yes.
Kelly's been coding that as mild. Is that correct or not correct?
Yeah, Amy just helped me out with that one, so that's good. Singular. I tell you, all these drugs, sometimes you forget what they are, how they work.
There's so many. Do I understand you to say that if we don't have criteria to determine severity, but provider documents a severity, we can code what the provider says?
No, that is not what I said. You cannot code lung disease based on what a provider documents unless he's documenting criteria. Okay. If he's documenting an ABG result or an FEV result, that's a different story as opposed to documenting the patient has severe lung disease. Maybe that's
I
where
think we should talk about this at AQO.
Oh yeah, I know. That's why we keep it. Yeah.
Okay, if the MD document COPD, but the PFTs and ABGs are normal, how do you code it?
I would say no to lung disease. You've got criteria. You have criteria to determine it there.
If an inhaler was on the med list for a few months ago, but not on a recent discharge list, how can you still code mild? The time frame of the last inhaler use is vague.
Well, we're talking about 2 discharge lists. What about the admission list, Gabrielle, that with the patient, was the patient on that medication prior to the index procedure? Send that in if maybe we can work through that together.
Okay. Criteria present from PFTs for CLD in the HMP MD doc. Jennifer's like alphabet soup. Okay, criteria present from the PFTs for chronic lung disease in the HMP. The physician's document patient has restrictive lung disease. It only has to be an MD, not a pulmonologist, to diagnose this, correct?
Okay, so I'm assuming you're talking about type, Jennifer, type of lung disease. So if the physician is documenting that the patient has a restrictive lung disease, and you can code that type as restrictive if the patient has chronic lung disease.
Okay. Thank you. If CLD severity unknown codes out as none, why would it be counted as a miss on the audit if the data manager entered no for CLD? Where there's
Well-
physician note, but no labs or inhaler.
It's kind of 2 different things in that. One is an audit looking at how you answered the question, and another is how the data is harvested. I mean, I don't know. Do you know what I'm saying, Carol?
Yeah, it makes sense. It's what Melinda, to put it in different words from what Melinda is saying is oftentimes the risk of two of the same answers, 2 answers for the same question have the same risk associated with it. But we still need to have the correct answer in the database, even though the risk is the same.
That's way better answer.
I don't know if it helped. If the bedside spirometry reports an FEV1 of 58%, but the results state poor effort, no interpretation possible, can we still code as moderate?
I tell people they need to clarify that report if there's, whether it was valid or not. I'm certainly not going to determine whether that's a valid test or not. And if it's not, if it's determined as not valid, then that needs to be documented in the medical record. This is not a valid test, and we're going to repeat it, or we're not going to be able to do it, or something. You guys need to work with your sites to figure out how to manage things like that when you clearly have documentation that this might not be a valid test.
What if asthma is documented, but there's no objective criteria? How is that coded?
I think you can still put lung disease with no severity, not known.
Are all patients on inhalers considered patients that have chronic lung disease?
Probably so. Per our criteria, it is.
Spirometry, this is not in the definition, right?
Yeah, it says we can use bedside spirometry. When did we change that?
Right here it is.
No, well, it's there, but it's also says we can use bedside spirometry. We had a big deal. We took that out one time,
Oh, yeah.
and then there it is. It's underlined right there. And then we brought it back saying, yes, we can use it.
Yeah, that was between versions. We had that.
Mhm.
Okay. Can we use the pulmonologist interpretation of type of lung disease on the PFT report? I don't use the pulmonologist rating of severity, but I do use the interpretation of type, obstructive, restrictive, etc.
That's perfectly fine. Yeah, to get your type.
And I'm not sure what this is, Sybil. It says I did not receive the help email that was sent out. I don't know what you're referring to, sorry. I sent in an FAQ a while back asking if we could use pre-bronch or post-bronch FEV1 and was told to use pre-bronch. So that's how I've
Okay,
been
so
abstracting. I think that was a previous version though, right,
it was a
Melinda?
that was in a previous version. We only used the pre-bronc, but then this, I can't remember when we changed. That's why when we have,
Well, in 2.9, didn't we go from coding lowest to highest FEV1? We had to change it in the training manual. And then
yeah,
we went to, it should be the highest FEV1 pre or post bronch. I think
yeah,
it was 2.9.
it's, yeah, that was a previous version. So, or that's why it's really important, guys, especially when we change versions to relook at the data definitions and relook at the intent, read your updates every month because things change. And this is a perfect example of something that definitely changed. And I just don't remember what it was. It's been a while though.
I said, okay, that one. Just to clarify, we can only code severity if there's a PFT, ABG, inhaler use, or steroids that are documented for respiratory issues. Yet, if an MD states moderate COPD, we can only code severity, COPD severity unknown, and it will be weighted by the registry the same as no COPD. Patients,
Well, yeah, you either got to have a PFT, an ABG, an inhaler, steroids, DLCO. You got to have some objective criteria. If you don't have any, and all you have is the doctor saying moderate COPD, then you say it's COPD documented, but I do not know what the severity is.
yeah, and the reason why the risk adjustment may be the same, and I'm going to double check, like I said, I'll double check with our analytics center. The reason why the risk adjustment may be the same is because if we don't have the severity documented, it's just the same with any variables that are risk adjusted variables. If it's provided as not documented or left blank, it goes to the lowest risk associated with that variable. So that's why I'm thinking that it probably goes to no, but we'll double check with the analytics center and report back on the next call.
And I'm sure the reason we did this as the database evolved is I've been doing this a very, very long time, and quite often everybody has some form of chronic lung disease. But so you see that documented all the time throughout records, but we have to have proof. We have to have proof, objective criteria proof that this patient has lung disease and what is the severity of it
Mhm.
to code it.
Sherry is saying singular is not an oral bronchodilator.
Well, see, I don't know. I got to look it up. I don't know what singular is. If it's not a bronchodilator, then
Oh,
you
somebody
can't
just
use it.
provided it. Sorry, I thought you thought it's hold on.
Yeah, I don't know what it is.
It's a hold on.
Yeah, so if it's not an oral bronchodilator, then we can't use it in that category. So,
But wait, hold on. It's we had so many questions today.
I know my head's starting to spin.
I know, hold on. It's a class of drugs called a leukotriene receptor antagonist. It works by blocking the action of inflammatory chemicals in your body that causes allergy and asthma symptoms.
So that's not a bronchodilator. So it wouldn't work.
Thanks, Sherry.
Thanks, Sherry. See, that's why you guys, when I answer these questions, that's why it's hard to answer these questions off the fly like we're doing now, because
Yeah.
when I answer these questions, when you send them in the mailbox, I look things up. Like I would look singular up and I would see what it is. Okay. Or I would go to my training manual and I'd look at the definition because I try to give you the most accurate information that's in the training manual that I can figure out. So sometimes when we're doing it off the fly like this, I don't always know the answer to your question because quite often I spend a little time researching to get the answer in the FAQ mailbox.
Yeah, and then if Melinda here, let's see, we have this is under chronic lung disease. The cardiac surgeon. So this is exactly what Melinda's talking about. She usually spends time looking at this.
Now, given the fact that it's down here, this may be something we might want to take to the surgeons and say, hey, would you consider singular medication? But that's a process that would involve going to the surgeons and getting their input and then updating the training manual. It's a good idea. And it may be something that we could take to them and say, well, what do you think about adding this as an oral agent, to determine. We can't change the definition though, but we can always clarify the intent.
All right, very good. The new user webinar will be recorded. And Pat, I'm going to get your other question in just a second. Thank you. And we appreciate you, Melinda, for all that you do.
Thank you. Sometimes I just think, gosh, guys, you guys this is probably one of the hardest jobs I've ever had. Because
I know it's fun, isn't it?
It really is. People don't realize how hard it is, but it's not an easy job.
Okay, and
I've had a lot of jobs. Okay, this is probably the hardest one I've ever had. So,
I just want to show Pat. So Pat has a question about the sign in for the new website, taking her to the portal or another to IQVIA. So to sign in for the training manual, etc., what I would do is this, I'm at sts.org, the research and data. I would just scroll down to the for data managers button. And then on the left-hand side, click on this adult cardiac and then access data collection resources, and it'll take you to the login page, or if you've already logged in, it'll take you right here. There's multiple ways to get here. I know that, and I know that when the home page, there's multiple ways to get here from the home page. Everything looks different. I just always try to do the same path. The other way to get there, I guess, would be this button, which looks totally different.
I don't
Different
like that
format. I don't either.
I like the for data managers. That seems to be the easiest.
Yeah, that's easiest to me because it's right at the top, and this access the database takes you to IQVIA.
Yeah, don't push that one unless you want to go to IQVIA.
Yeah. And then here, and then access data collection. I don't know if I haven't had a chance to look at this close enough, but these are nice tile things.
I'm still trying to get used to it myself.
I think this data collection form will.
That's how I'm teaching it tomorrow. This is the most direct route that I've found to get to it.
Yeah. We just got to click and see which way you like the best. Okay. Do hospital treat abstractors poorly after audit results? I certainly hope not.
I hope not. I think audits are learning experiences more than anything. And I would hope not. Yeah, that would.
Yeah, I hope not. Everybody loves you, Melinda.
Thank you.
Teresa appreciates it, says usually things are not. Kim says, isn't it a great feeling to be so needed?
Oh, I need every one of y'all every day too. So we all do this together.
Yeah. Melinda and I laugh a lot when we review some of these questions. Okay, is there not these questions on the webinars, but the FAQ questions, because we're like, oh my gosh, we're learning something new. Is there a link for tomorrow's data manager webinar? So sts.org research and data for data managers. If you scroll down, you'll come to the ACSD section, or you could just click here, and then the webinars are here. New data manager webinar, join webinar link is here. So it's there. You'll find it. Don't worry. I know you will.
And it's a 2-hour call, guys. But
yeah,
we have a lot of fun on it. So
it'll be good. And I'll try to join the thank you. People appreciate me too, Melinda.
Well, of course.
But you're more loved. Okay. Let's see, a couple more and then we'll be done. I must have missed the answer about a singular inhaler.
Well, we had, first I said singular didn't count because in my mind somewhere I thought I answered that question, but then Amy told me it was a bronchodilator. So I got confused, an oral bronchodilator. I thought, well, if it is, then it counts. But then Sherry says, no, it's not. It's that leukotriene receptor. So that's something I need to take back to the surgeons. I think we need to maybe see if drug like that category should be considered in the criteria. So you really didn't miss the answer. You just kind of, I guess, the whole conversation, it was kind of realization on my part. See, that's why I need you guys to.
Yeah, TBD. We're going to talk about it more.
Yeah, I got it on my list.
Thanks, Hannah. She says singular is not an oral bronchodilator. It may be used for other things as well. So we'll review it with the surgeons. That's good to know. I think we saw it could be used for severe allergies and things like that.
Right. So, it's something I need to research it. Bring up a good point, guys.
Yeah, we'll find out. Don't worry. Melinda will find out and I'll support her along the way. Okay. If the MD writes COPD, the FEV1 meets mild, can we code the type as obstructive?
I would, because
Okay.
COPD falls into the obstructive category.
Okay, this is really not a question, but Sharina wanted to share. They had a discussion with their providers and decided to make diagnostic testing, such as PFTs, for patients with any history of compromised lung, smoking, COPD, asbestos, etc., so we can document objectively. This is in relation to our reviewing our prolonged vent data. So that's really great to share. Thank you, Sharina. I think that's good feedback to get PFTs on everybody who has any type of compromised lung. So thank you. Pat Hobbs says, I missed Linda's answer to this question. I don't know what that was. See, the questions, once they're answered, they go into a whole different thing, and there's 105 questions over there, so I can't
We can't figure out which one it
go
is,
through
Pat.
the whole 105 because I have to keep scrolling, and then there's long pauses, and it's uncomfortable. Just to clarify, we can only code severity if there is a PFT, ABG, inhaler use, or steroids that are documented for respiratory issues. I think we already did this one. Yeah, we did that other Pat Hop.
Oh, maybe that's the one Pat wanted us to address.
Well, no, we already did. We already did
but
address
she
it. I
says
said I
she
have to
missed-
check with the.
She
Oh, I
says
have
she-
to check with our analytics center to make sure. And the reason
Right.
why we're saying that from the risk adjusted side is that if we don't have severity coded, or if, for any of the risk models, if it's coded, if it's left as blank, or it's left as not documented, or whatever it would be, that wouldn't show a specific answer, right? It's leaving it open to interpretation. It defaults to the lowest risk associated with that variable. So you still need to code it correctly so we have the correct answer in the database, but for risk modeling purposes, that's what happens with the data. Okay, are we good?
I'm good.
You guys good? Okay, we're gonna have a call tomorrow, don't forget, and hopefully you can join. No, the lowest risk isn't mild, the lowest risk is no. So let me double check with the analytics center. Typically, when we're looking at the lowest risk, we're looking at a risk of no when severity is not provided, but I'll double check with our analytics center to make sure we get to share the right information on that. But in general, the way risk modeling works is that if severity isn't provided or if the field is left blank, we default to the lowest risk associated with that variable. And mild may have the same risk as no. That's another thing, is sometimes the lowest two risks are very similar in the way they work in risk adjustment. But I'll find out and we'll report it back. Probably not tomorrow, but probably on our next call. And that's what I was just looking for. So we have a webinar tomorrow the new data manager webinar at 2 p.m. Central, and then a quality improvement webinar on June 21st. I hope everybody's working on decreasing vent times and improving early extubation where appropriate. Nancy Honeycutt's going to present for us maintaining early extubation rates of 88% for over 3 years. All right, so there we go. Thanks everybody for joining. I hope you have a good rest of the day. And yeah, I like the Q&A format too. We share a lot of information on these calls, and we had 108 things come over through the Q&A. A lot of those were thanks to Melinda and how wonderful Melinda is, which is great, but still quite a few attendees and very nice feedback for us. So thank you so much. And we're going to get going. Thanks, Melinda.